Now I invite Dr. Lakshmi C. She is a pediatric ophthalmologist from MMC, Calicut, and she is also working in Abate Hospital as a consultant, as a part-time. And she is going to present an interesting case on the topic of her case is the same eye with a different tail.
Thank you, Dr. Soumya and KSOS for the opportunity. So, after these interesting cases, I'll just go on to another case, which I don't deal regularly, but definitely we can diagnose from the beginning as a general ophthalmologist and a pediatric ophthalmologist. So, the same eye with a different tail. So the story is of a child who was being followed up with us from 1 year of age, and the mother had a very strong suspicion. As shown in the previous case by Nirmal, the mother was very doubtful that the child is having poor vision at night, and they had a family history of defective vision and retinitis pigmentosa in a paternal aunt. And the child was having myopic astigmatism on refractive error evaluation. Fundus examination was within normal limits except for some minimal pigmentary changes in the mid periphery. This was at 1 year of age. And later, this is not the child's ERG. The child was investigated with an ERG, and it was diagnosed as an atypical retinitis pigmentosa and at 2 years of age. And the child was kept on follow-up, and the child was being regularly followed up until around 8 years, when the child's refractive error was remaining the same. The best corrected visual acuity was around 618, and he was evaluated with a dilated fundus examination. So undilated, it was quite remarkable, except for the pigmentary changes in the mid periphery, until I did a dilated fundus examination and saw some telangiectatic vessels with hard exudates in the inferotemporal quadrant of the right eye. So I sent it for a retina opinion, and they diagnosed with a fundus fluorescent angiography. The typical light bulb appearance was seen. So there was peripheral capillary non-perfusion areas, telangiectatic vessels. So they diagnosed it as Coates-like response in a patient with retinitis pigmentosa. He was advised laser photocoagulation and genetic screening, but lost to follow up after that. We are still calling upon him because it's been only 2 or 3 months. So Coates-like response can be seen in various sorts of genetic syndromes like Turner syndrome, senior Loken syndrome, retinitis pigmentosa, both syndromic and isolated, facioscapulohumeral dystrophy, Parry-Romberg. So all these can present as Coates-like response from the literature. It was first described by Zamarani, and it's seen in 1 to 5% of all RP patients. And the feature that makes it distinct from Coates is that it's seen more in the inferotemporal quadrant, could be bilateral, and there is no male gender bias, and it's usually seen in the setting of a retinitis pigmentosa. According to literature, the earliest reported age is 4 years, and the onset of RP to the diagnosis of Coates is variable. It's not, it could be from few months to few years. And it has also been told that vasoproliferative tumors and Coates-like responses are actually two sides of the same coin with similar features in FFA and clinical. And it has been proposed to be the different stages of the same disease process. Genetic association is most commonly studied with CRB1 gene, though there are other mutations which have been reported. And most of the cases come with a positive family history of RP. Pathophysiology is still obscure. It's supposed to be some of the degraded products of the photoreceptors, which is initiating a vasoproliferative effect. So it's not clearly understood why it comes so. And treatment is mainly laser photocoagulation, carbonic anhydrase inhibitors, and intravitreal VEGF in macular edema. So these children could present as extensive vitreoretinopathy along with macular edema, and they can lose vision. And if we treat them early, we can save vision in those eyes. So a risk of added visual loss is there, and the general ophthalmologist and the pediatric ophthalmologist should be aware of these changes. And a routine dilated fundus examination is mandatory. Even if the patient has already been diagnosed of RP, we know that it's not going to change and it's ERG proven. Still, we need to do a routine evaluation. So there are a lot of genetic diseases which can change their form or phenotypic expression with time. So if we just be a hamster inside the wheel, we will not be looking at the bigger picture. So we need to see all these things when you see a patient with a known disease to not to miss out all these variations. So the same eye can tell two stories. The time it takes is just a dilated fundus examination. So thank you.
Thank you, Dr. Lakshmi. It was a very interesting case and a good pearl for us too, because courts associated with RP have not seen any
And
case
this is
like
the
that.
first case I'm seen. I don't know, madam, but okay.
And that does emphasize the point that every child, whenever they come, even for a follow up, we need to have a dilated examination and not to miss out such cases, because early detection will prevent the further visual loss which the child can
And
have.
this was a case in which it was a localized courts-like response. All the reports which I have read, it shows extensive courts-like response in more than one or two quadrants and bilateral involvement. So this could be an early onset. So similarly, one case of intermittent exotropia, as Rashmi madam had told, like initial time when I saw, the fundus appeared normal, but in children you can't tell, like sometimes you need one or two assessments. So, on follow up after 2 months, she had a torpedoretinopathy. So initially I thought it was an intermittent exotropia, but she had that thing. So, and it is said that some genetic diseases can change phenotypes over time. So if it is a child, then repeated follow up is necessary.
In a child, it's unfolding. The clinical spectrum is unfolding. So in the early stages, you may not get the full-blown manifestation of the disease. But as the child grows older, we will be able. So that's, I think, genetic evaluation is very important, because there is a strong family history of photoreceptor dystrophies, and prognosis-wise also, it's important to get it done.
Done. Yeah.
Some retinal problems. Schisis is one, especially X-linked. It is usually in boys, but many retinal problems can, in the initial stage, present with intermittency. So, intermittent exotropia, we need to look for any fundus pathology
Every time.
If they're cooperative for OCT, I get it done, because it's very difficult sometimes to do a 90-day exam and pick up everything, because the child is moving so fast. And we have picked up so many things, like, so many conditions. And before labeling as amblyopia, we should be 100% as a non-organic amblyopia, we should be like, sure about our diagnosis. No, children usually above 5 years will cooperate for a regular OCT.
And the other thing is, we will literally be heartbroken if we miss something like this on, a patient who regularly comes to us for follow-up.
Yes.
This also scares me, actually. Usually I write next visit dilated evaluation. At least once in a year, it is always better to get, because you don't want to miss out on anything, especially on a patient who is under your follow-up for so many years.
That's true.